Hi, I'm Kristen Hodgden, IVF mom, proud women's health advocate, and co-founder of Rescripted.
And I'm Dr. Jenna Khan, a board-certified OBGYN, fertility specialist, and mom of two.
And from first period to last period, we're diving into the women's health topics that matter most, from periods and fertility to pregnancy and menopause.
Through expert interviews and candid conversations, we're empowering women to take charge of their health by expanding the discussion beyond what's typically covered in the doctor's office.
It's time to stop guessing when it comes to our health. Now let's dive in for the real science-backed info you need to be the expert in you. Hi, everyone, and welcome back to From First Period to Last Period. We just came off a great episode last week about BV and heavy periods. So if you missed it, please go back and listen wherever you get your podcasts. Hi, Jenna.
Hi. Good to see you.
Good to see you too. So I just came across this article that I thought was pretty funny because, well, funny slash interesting because we've been talking a lot about like diet culture and wellness trends and how they, kind of go after our insecurities as women. And I just saw this article in Women's Health about how juice cleanses might actually cause inflammation and disrupt gut health, according to a new study. So bad news for gut health girlies who love juice cleanses. The two might not be so compatible. And I know you read it as well and found some interesting takeaways.
For sure. I think like finally something is coming out about this. Not that I haven't done my own research in gut health and juice cleanses, but, the article talks about how, being on a juice cleanse can disrupt the bacterial environment, the normal healthy bacterial environment in the gut and lead to a bacterial profile that is associated with cognitive decline. And, I don't know if you've ever tried a juice cleanse. I tried it for one day and certainly felt like a foggy, not myself, hangry.
I am notorious for being hangry.
Yeah. So I think that the findings of the study just make a lot of sense to me.
Yeah, no, for sure. I don't know.
And we talked about last time, like how, like last episode, how Anna was talking about how you don't want to be starving yourself and you want to be nurturing your body and
intermittent fasting. Yeah.
Yeah. And so sounds like even like a juice cleanse, like isn't really necessary. You really want to be giving yourself whole foods to reap the benefits, the nutrient benefits of them.
No, yeah, absolutely. Well, I guess the argument is that when you're juicing, as opposed to having the whole fruits, you're eliminating a lot of the fiber. And that's one of the really important nutrients that we get from fruits and vegetables. So aside from basically starving yourself, you're not even getting like the nutrients that you think you're getting when you're juicing. So, not to say that juice isn't healthy every once in a while, but like if you're just existing
like
on
people
that.
like pick me up. Like I love juice, but I mean, I really, taking away whole foods and completely supplementing with only juices is what this study is looking at.
Yeah. And I feel like I've been seeing a lot about, obviously this can impact gut health and lead to inflammation and stuff, but like the tie between gut health and cognitive decline is really interesting. Like I feel like so much more research has been coming out about like Alzheimer's and dementia and how to keep your brain healthy. And so I feel like that's something that we've been keeping an eye on and hope to cover more at Rescripted.
Sure. Yeah. The gut is really integral in so many different processes of your body. It's not just digestion. It's like hormonal regulation and your immune system is all sort of interplays with the gut.
Absolutely. So yeah, we'll put the article in the show notes if you guys want to check it out. So we've got an amazing episode for you today, as always, if I do say so myself. First, in her story Unfiltered, Sarah shares her women's health horror story, which includes an ectopic pregnancy, a ruptured fallopian tube, and how it influenced her decision to pursue a career in nursing. Love a good pain into purpose story. Then in Own Your Health, we're going to answer your most burning questions about fertility, specifically how to improve egg quality and what supplements Jenna recommends to her patients who are trying to conceive, and overall your kind of sentiment on fertility supplements. And lastly, in Women's Health in the Wild, we're going to be chatting about ongoing research into ovarian cancer detection, as well as the latest guidelines for pap smears and mammograms. So yeah, let's get started.
Her Story Unfiltered, raw, real, and rescripting women's health, one powerful story at a time.
My name is Sarah Rivera. I am 38 years old and I live in Barcelona, Spain. The first time I got pregnant was in 2013 and it was a complete surprise. My husband and I had been married for 2 years, and with my irregular periods, I didn't think it was even possible to get pregnant so quickly. We were overjoyed, and I immediately sought care at a well-known birthing center because I wanted to deliver naturally. At first, everything seemed fine. My initial blood work came back with great numbers, but at the second beta, my test revealed that I was going to have a miscarriage. I was devastated, and I was told that it would be like a heavy period with some cramping and to let it happen at home because it was very early. The bleeding came and went, and I thought it was over, but then I had excruciating lower back pain and cramping about a week later. When I called the on-call nurse explaining my symptoms and my history, she said it was likely hemorrhoids. At this point in my life, I didn't know what hemorrhoids even were. She didn't offer a follow-up scan, no lab work to confirm my HCG levels had dropped to 0, nothing. So I was very desperate at this point to distract myself, and we drove 6 hours to my hometown in Texas for a weekend festival. But unbearable pain again landed me in the ER. There, a doctor told me that I needed emergency surgery. She saw free fluid in my abdomen. And after the surgery, when I woke up, she told me that my left fallopian tube had ruptured, and I had been bleeding internally for weeks from an ectopic pregnancy. A year later, I tried to conceive again, and this time I had another ectopic pregnancy. I had a corneal ectopic, so this time my uterus ruptured. And after this, it's when I decided to go back to school and become a nurse. I wanted to, and I am, dedicating my career to supporting others through their fertility journeys and to educate women about their reproductive health care.
Thank you so much, Sarah, for sharing.
Yeah, I mean, I'm really interested in learning more about ectopic pregnancies because I feel like that's always like the fear when you first, like I've had a low beta number before. For those of you who don't know, the beta is the blood test that you get at the fertility clinic to measure your HCG levels after, fertility treatment in early pregnancy. And yeah, I got a low beta and I kind of freaked out about that being the case. And it ended up being like a blighted ovum, which is a totally different story, but an early miscarriage. But yeah, I'm so sorry for your loss, Sarah, and I'm so sorry it went down that way. Like, what stuck out to me was that your doctor said it was probably hemorrhoids. Like, that's probably warranted further inspection.
Yeah. So ectopic pregnancies are pregnancies that implant outside of the uterine cavity, for anyone who doesn't know what they are. They are most commonly in the fallopian tubes, but may occur like in the ovaries, in the abdominal cavity, in the cervix, in an old C-section scar. And she also talks about a corneal ectopic, and that means that the pregnancy implants where the tube and the uterus meet, like in the very corner of the uterus, where there's not a lot of surrounding muscle of the uterus, and so it's like really thin, and so those are particularly rare and particularly dangerous because if they rupture, they can result in life-threatening bleeding. Wow. Ectopic pregnancies in general, all of them, no matter where they are very dangerous because if they're not caught early, they can continue to grow. And then when they outgrow their blood supply, the place where they are just breaks open and you can have internal bleeding. Ectopic pregnancies are, again, as I mentioned, they're rare. So make up of 1 to 2% of all pregnancies and can be diagnosed when someone has a positive pregnancy test and nothing in the uterine cavity on ultrasound. And a pregnancy is seen elsewhere in the body, like again, in the tube or like on the side of the ovary and in the ovary, in the cervix.
And are they never viable?
You can't transplant them from one place to another. And so while they, go ahead.
No, because there's this influencer on Instagram who had a C-section ectopic pregnancy, or C-section scar ectopic pregnancy, and she was kind of told all the risks, but she really didn't want to terminate the pregnancy, and she ended up, staying pregnant, and she ended up she gave birth early, obviously out of precaution, but she had a healthy baby.
Yeah. So these are just really, really high risk pregnancies because
Yeah.
there's like very little muscle surrounding the pregnancy. And I guess it really depends where
Where it is.
it attaches, like where it implants. Is it like on the edge of the C-section scar? Or is it like within the defect where the scar is? And
Hmm.
they can open up and cause like fetal loss, like pretty late, or like severe pain and hemorrhage.
Hmm.
And that can result in like a hysterectomy, a
Yeah.
cesarean hysterectomy. And so most of them, it's recommended to like end the pregnancy out of a safety precaution.
Hmm.
Um, but I guess it's not impossible for them to continue to grow, but usually will deliver early and, have the patient be like hospitalized if they are,
Yeah.
for a long duration of their pregnancy for monitoring, if they, don't want to terminate the pregnancy.
Yeah. Well, I'm assuming the fallopian tube, you definitely can't.
You definitely can. And then with a cornual pregnancy, like those will break open too, like what happened with Sarah. So,
Mhm.
and as you mentioned about like the low beta, and what I tell everybody is like, certain like the first beta HCG certainly can be reassuring if it's above a certain level, but it really tells us nothing about what type of pregnancy it is or the health
Yeah.
of the pregnancy. It's really the way that the hormone level rises over time that informs us about the health of the pregnancy. And so with an ectopic pregnancy, sometimes the hormone level doesn't rise in an appropriate way, like doesn't rise enough, like at least 53% in 48 hours. Sometimes you see like a drop and then a rise, a drop and then a rise, which is probably what happened with Sarah, where her pregnancy hormone level dropped and then maybe it went up a little bit and then down. Um, and Also, they're associated with a low progesterone level that can sometimes, raise a little red flag. When I see a patient with an abnormally rising beta and a low progesterone, I'm not thinking like I need to
Mm.
look closer, for concern for a potential ectopic. Um,
We know too much in the fertility world.
I know, I know.
Like
Um,
some people would get a positive beta and be like ecstatic, and then there's always me that's like, but has to be
Cautiously
double.
optimistic.
Yeah.
Yeah, it's a
And so what's like the prognosis of future pregnancies for someone who's had an ectopic?
So it really just depends on where the ectopic was. Like if and how it was treated. So let's
Yeah.
say you have an ectopic pregnancy in the fallopian tube. If you catch it early, you can utilize methotrexate
Hmm.
to, shrink, like stop that pregnancy from growing, and it'll shrink and sort of the body will reabsorb it. And, while ectopic pregnancy and the subsequent pregnancy that risk is higher, you still certainly can get pregnant in an unassisted way through that fallopian tube.
Yeah.
If the pregnancy has ruptured, then your only option is surgery. That's like a life-saving kind of surgery.
Yeah.
So if you only have one fallopian tube, you still can get pregnant in an unassisted way. You know, in a when most of us think about the pelvic organs, we think about that textbook picture. It's like the uterus and the two fallopian tubes like stretched out on either side with the ovaries. But actually in the body, it's like the uterus and the fallopian tubes and the ovaries just sort of like hang behind the uterus together. And so you can have cross pickup, meaning you can ovulate from one side and the other fallopian tube can pick up that egg. And so even if you just have one fallopian tube, yes, that
Is
yeah.
this
So
anatomically
so
correct?
like put the arms behind its back. That's like actually how it is. Yes, that
Okay,
is actually how it is.
got it.
And
And
so
these
you can
are
have
the
cross
ovaries?
pickup. Yeah. So if you ovulate from one side, like the opposite side of where you have the tube, like if the other tube is nearby and it's
Yeah.
open, like we can pick up that, that ovulated egg. It can
Okay.
just take longer. Like the time to pregnancy can be longer if you just have one fallopian tube, but it certainly is possible.
For those of you who are just listening and not watching, I held up my stuffed uterus from ASRM, I think 2 years ago, and at this point, my kids have played with it. My dog took a chunk out of it, but it's like one of my most prized possessions.
Yeah. And then when it comes to like corneal ectopics that need to be removed, that requires like a wedge resection, like a removal of a portion of the uterus. And while people can still get pregnant, those are just higher risk pregnancies. And usually a delivery via C-section is needed at an earlier time point, like close to 36 weeks.
Yeah. Always worth having like a really detailed conversation with your doctor about like the risk benefit analysis.
For sure. And just to mention like some risk factors for ectopic pregnancy, it would be like a prior history of pelvic inflammatory disease from gonorrhea or chlamydia, or a ruptured appendicitis, prior pelvic surgery like fibroid removal surgery, or like endometriosis surgery from endometriosis, or just endometriosis in general that can cause a lot of scarring in the pelvis.
Oh, wow.
Smokers. And then also, as we sort of mentioned, the risk of having had a prior ectopic pregnancy is probably the biggest risk factor for having another one.
Yeah, but if it's well treated, the odds are good that you can go out and have a successful pregnancy, correct?
For sure. I think that, in my opinion, if someone has had a prior ectopic, any subsequent pregnancy just needs to be followed really closely.
Okay.
But like the more common thing is that they're going to get pregnant with a completely normal pregnancy in the next one.
Awesome. We'll end on the note of hope. But I'm so glad that Sarah was able to kind of turn her pain into purpose, like I said, and put her energy into nursing and helping other people. It's awesome.
For sure. Her patients are lucky to have her. She's been through a lot and can really empathize with her patients, I'm sure.
Absolutely.
Own your health. Ask us anything. Your questions and expert answers, because you are your own best advocate.
So in this week's Own Your Health section, we're kind of getting into the nitty gritty when it comes to fertility and egg quality. I know this is like the $1 million question, but several people wrote in to ask how to improve egg quality in like specifically in, I guess, mid to late 30s. Any advice there, Jenna?
Yeah, so I get this question a lot, and I'll just sort of start off with like the story that I've said before on this podcast, and is that women are born with all of the eggs that they'll ever have in their life, and they're stored in the ovary. And eggs that have been sitting in the ovary for over 35 years have an accelerated decline in their quality, which means the DNA inside of them gets sticky with time. So these older eggs, when they ovulate, they may contribute an abnormal amount of DNA to the pregnancy, which results in increased rates of miscarriage and infertility. The biggest influencer of egg quality by far is age. And there's no other test for egg quality. We can only make assumptions of the quality based on age, and the success rates that we see in natural pregnancies and, in the decline of IVF success rates with rising age. Environmental factors may influence egg quality, but to a much smaller degree. We know that women with obesity have poor egg quality, and achieving a healthier weight may help improve that quality. In patients with PCOS, optimizing weight and insulin resistance can also help with egg quality. So treatment of that insulin resistance, which can be helpful. So that can involve some dietary changes along with the medication metformin or the supplement inositol. It can be really helpful.
I don't think I knew about the connection between weight and egg quality.
Yeah, that's a big one. There was actually like a big practice guideline from ASRM that was published on obesity and infertility that really highlights a poor egg quality in those patients.
Got it.
And then it's also important to avoid toxins like cigarette smoking, vaping, heavy alcohol exposure, and then more than 200 milligrams of caffeine per day.
Mm-hmm.
And then when it comes to supplements to improve egg quality, which I'm sure this is sort of what, the question is really getting at, like what else can I do to improve my egg quality? CoQ10 or coenzyme Q10 is probably the best studied supplement. CoQ10 is an enzyme that is essential for mitochondrial function, and mitochondria are the powerhouse or energy compartments in every cell and are essential for many functions inside of the female egg, such as segregation of the DNA into like even parts, and egg maturation, fertilization, and embryo development. And some studies show a significant improvement in embryo quality and in pregnancy rates in those taking CoQ10, but other studies show no difference. I do recommend CoQ10 to my patients who are in their late 30s, and the dosing is 600 milligrams per day in divided doses. So that can be 200 milligrams 3 times a day or 300 milligrams twice a day. And you can imagine I've like sort of Amazon or Googled CoQ10 supplements on the market, and most of them actually only have like 100 milligrams in them. And so you really want to be looking for a supplement that has a larger quantity. Otherwise, you're going to be taking a ton of pills.
Yeah.
Yeah. So one of the ones that I recommend to patients is called NutriBloom. It's like one capsule has 600 milligrams of
awesome.
CoQ10 in it, but there are others, and I can't tell you that one is better than the other.
You know, that's really good to know. I feel like sometimes you don't look at the serving size until you get home and spent $50. And you're like, no, I don't want to take 4 pills.
Right.
So, I mean, I know like you probably have a lot of patients that come to you with like, oh, I'm reading it starts with the egg, or I'm, like all of these other fertility supplements that wellness, influencers say that I need. And like, what is kind of your response to that?
I've had a couple patients like this who, we go through the whole reproductive physiology. We talk about decline in egg quality. And then at the end, they're just like, but what about this supplement? And what do you think about this brand? And it's a hard conversation to have, because patients are really just looking for something that they can like sink their teeth into and have some control over this process. And I think supplements sort of provide that, like, this is what I know I can do to help my future fertility. And while these may help, I think that the data is a little bit mixed in whether there's like a true association or a true benefit. And so, in patients who have like poor egg quality or who are in their late 30s and are having continued miscarriages related to like aneuploidy or abnormal amount of chromosomes, IVF can be really helpful, because you're sort of like digging through, you have a lot of eggs that you're able to sort of sort through natural selection and embryo development to find the one that's going to result in a healthy pregnancy.
Yeah. And we spoke on a previous episode about like how like women with PCOS specifically can have a higher egg reserve, but sometimes the quality can be an issue. So IVF can actually help weed
and in those patients,
out.
like I mentioned, like really treating the insulin resistance can help a little bit with that egg quality issue in PCOS patients. I have seen improvements in patients who've started metformin in between IVF cycles.
Yeah. We talked about gut health in the beginning of the episode, but I would be interested to like if there were research down the road that could kind of connect the two also, like could gut health
there have been some studies on like special diets for fertility, and really the only one is like a Mediterranean style diet, which is really good for your health in general. So that's lean proteins, leafy green vegetables, whole grains, that no processed sugars, that sort of thing.
We keep repeating this, but like kind of going back to the basics and like getting good sleep, eating good food, not drinking too much, not smoking, like just kind of getting back to the basics can really help.
For sure. And I think that a lot of people are surprised to hear that caffeine part, that caffeine can impact egg quality. There was a lecture at ASRM this past year of a researcher in California who was looking at embryo development, and it was I believe animal embryos. It wasn't human embryos, or they were grown like embryoids in the lab, and exposing them to different toxins. And I just vividly remember this slide that she posted about the embryos that they exposed to caffeine, like high caffeine intake. And the results, the outcomes were sort of drastic in the decline of good quality embryos when exposed to like high caffeine intake. And so I
Wow.
share that with my patients. I think it has more of an impact than we think. And of course, again, like this wasn't done in like human studies. I think that would be a little unethical at this point,
Yeah.
but it really does have an impact.
Yeah. I feel like I still have like fertility treatment carryover guilt about like drinking too much caffeine and like like I just feel like for so long I was in this space of like I can't go over one cup of coffee or like I can't have more than one glass of wine or like, and I'm still like somehow in that mentality and I'm like wait no I can finally like let go a little. But you just get so used to like restricting, and that's what makes the emotional part of it so hard too, because you're like essentially having to treat your body like it's pregnant when it's not yet.
Yeah.
And that is such, I don't know, it's such a mind game.
Yeah, there's a big mental load there too.
Yeah, absolutely.
Women's Health in the Wild, must reads, must sees, and must tries for your wellness journey.
So I'm really excited about this, sort of piece of research that I came across for ovarian cancer. So researchers have developed a highly sensitive blood test for early detection of ovarian cancer, potentially improving survival rates for this often late diagnosed disease. So obviously this isn't like ready for widespread use yet, but wanted to hear your thoughts, Jenna, on like, well, first, I think ovarian cancer is such like a mystery to so many
Yeah,
women.
yeah.
And like I said, it's often late diagnosed. So can you kind of go into what this means and like how people can screen for this disease?
Sure. So currently there are no good screening tests for women who don't have symptoms of ovarian cancer, which makes early detection really difficult. The test is called Ovaprint, and it is a blood test that looks for specific changes in DNA that can indicate the presence of a tumor. And the
Mhm.
technology that's being used is called cell-free DNA, which is picking up DNA that's shed by the cancer in peripheral blood or like just in a normal blood sample. And other places where you may have heard about cell-free DNA is the NIP test or the non-invasive prenatal testing, which
Mhm.
actually looks at circulating fetal DNA in the maternal bloodstream to screen for chromosomal issues with the pregnancy. So it's like same, but different, using the same
Yeah.
technology for a different purpose. Um, and so in this study, they found that this test could accurately identify 95% of women with a specific type of ovarian cancer. It's called high-grade serous ovarian carcinoma, and correctly identify 88% of those without cancer. And this
Oh, wow.
performance is way better than any existing tests. So the researchers believe that this test could be a valuable tool for doctors to assess the risk of ovarian cancer in women with pelvic masses, potentially leading to earlier diagnoses and better treatment outcomes. But further studies are needed to confirm its effectiveness, especially for women who don't have any symptoms. And again, so symptoms are pretty vague. They don't usually show up until the disease is really advanced. And that might be abdominal bloating, pain, feeling full with eating small amount of meals, or a small amount of food, fatigue, weight loss, nausea, vomiting. And so like you're thinking like, do I have those symptoms? They're
Yeah,
like really vague. They're really, really vague,
we
which
all
makes,
have those symptoms.
yeah, so it's really, really hard to make the diagnosis or just really screen for it. And so this could be a great tool to be just like checking a blood test just to detect the cancer.
You said they have to have symptoms before they can.
So so when someone has a pelvic mass, there are features on imaging like ultrasound or MRI that may suggest that it's malignant or not.
Mhm.
And current tumor markers are just not that sensitive to help distinguish that. And so sometimes that may result in unnecessary surgery or complex surgery to figure it out, or just like watching and waiting for a little bit longer because it doesn't look that suspicious. So having
Yeah.
something that's a little bit more sensitive, that's minimally invasive, it could be a huge benefit to the field and
Yeah.
for patients, because this is uh, ovarian cancer is a very deadly cancer just because you don't find out about it until it's has progressed.
Ugh, I know that like keeps me up at night kind of.
Ovarian cancer in young women is extremely, extremely rare. I think
Yeah.
if you've got a family history of it, that's something to bring up with your OBGYN. Um, but at this point, there are no recommendations for routine screening for ovarian cancer because it is so rare.
Yeah. Well, so I know we're going to talk about like, mammograms and stuff too, but during the IVF process, actually, and don't quote me on any of this because I don't know a ton about it except for the fact it was during my genetic carrier screening, and I tested positive for a, the ATM gene. So it's not BRCA, but it does increase your lifetime risk of breast cancer, ovarian cancer, and I think pancreatic cancer. So honestly, overall, it was a good thing because now I qualify for mammograms at 35. Or I started last year when I turned 35. So it's just like peace of mind knowing that like I know about it and that we're screening. And I mean, I need to get mammograms and sonograms every year and an MRI in the 6 months in between. Like that's how much I need to get screened. Um, and I
But, I
feel like
mean, this test could potentially be helpful for you in the future. Like, let's say you develop if this test is brought to market, which in the article they were hoping to like bring this to market within the next couple of years.
mhm,
If there's ever like a concern, is there a cyst that's growing? Is there something that
yeah.
or a mass that looks a little bit atypical?
Mhm.
Is there something more like less invasive that I can do to either reassure myself or give me more confidence that surgery is the best option for me?
Yeah, I mean, because sometimes it's like as simple as asking for a blood test. Like, obviously, this one's not available yet, but with the genetic carrier screening, like that's literally a blood test, and it's
Yeah.
not invasive, and and now I know. So, well, speaking of breast cancer, wanted to chat about like mammogram guidelines and also pap smear guidelines for cervical cancer, just so that everyone kind of stays in the know. I know that the pap smear guidelines have kind of changed in the past couple of years too, right?
Yeah. So, um, a pap smear is the way that we screen for cervical cancer. And screening starts at age 21. And if the testing is negative, screening is repeated every 3 to 5 years, just depending on your age and the specific test that you had done, like whether just the cells were tested or if HPV was tested for additionally.
Hmm.
And then if the testing comes back abnormal, then again, based on your age and the type of abnormality, there's this whole algorithm that tells you which testing comes next, and that has become a little bit more nuanced. And so there's actually like an app that OBGYNs use to sort of like plug in, like here's the age, here's um, the the cellular abnormality that was found on the pap smear, like what are the next steps. You usually, like if there's an abnormality, the next step is like colposcopy, which is a specialized microscope that looks at the cervix, and if there's anything that looks a little atypical, then a biopsy is taken. And then
Hmm.
like the additional next steps or continued screening or surveillance is based on what you found in the biopsy, and you could find that on the app. If if during the surveillance the pap smear has become normal again, which is very possible that it just sort of resolves on its own, then after a certain period of time, you sort of go back to the low risk screening schedule of every 3 to 5 years.
Okay, got it. I think I used to think that, and I think a lot of people think this, that because you get an annual every year, that you get a pap smear every year,
Yeah,
but
and I
that's
sometimes
not
have to
actually
make that clarification for patients. Like just because you had a a speculum exam and they like looked in there, they looked inside the vagina, doesn't mean that they actually took a sample of the cervical cells with the pap smear. That's like a little brush that they use.
Right. So you can kind of think you had a pap smear, but you should probably ask if you actually had one.
Yeah, and like if you're up to date. And especially if you're like changing providers and you had a pap smear done at one place and the new place doesn't have your records, like making sure you're up to date or getting those records sent over so that they are, you're getting the appropriate screening in a normal time interval.
Love it. And then what about mammograms?
So mammograms start at age 40, unless you have a different, you have an increased risk. But for patients at average risk, mammograms start at age 40, and they should be repeated every 1 to 2 years. Of course, if something suspicious is found, that will change the screening or the diagnostic approach, whether it's like MRI or a repeat mammogram in 6 months. But really talking to your OBGYN about your personal breast cancer risk is really important, because screening recommendations just might be different. And really, I sort of think about breast cancer screening even before age 40. Clinical breast exams at the OBGYN started in the mid-20s. But what I think is even more important is just self-breast exams every couple of months. So you have a good understanding of what your breasts feel like normally. So you can detect if something just feels different and bring it to the attention of your OBGYN.
Yeah, absolutely. One of my best friends actually passed away from breast cancer when we were 31. And
I'm so sorry.
Thank you. But we have her husband and friends, and I help out with social media sometimes, started a foundation, and we constantly preach feel it on the first. So like you can literally set a reminder in your phone for the first of the month just to do a self breast exam, and then you
like in the shower,
you
just
get it over with,
get a good sense of what
for
it
the
normally
month.
feels like.
Exactly. And obviously if like you're breastfeeding or something, like I ended up having a little bit of an abnormal, like I just felt something when I was like a couple of weeks postpartum, and it ended up being milk, and I was like, that was really scary.
I actually had my first mammogram a couple months postpartum. I was like done breastfeeding and, just doing my usual checks, and I felt a mass, and I brought it to the attention of my OBGYN. We got a mammogram, which is not comfortable. It's not an exciting thing to do. But it was a cyst that was followed, and then thankfully just went away. But, knowing what your breasts normally feel like is like the first step in detection, because you don't see your OBGYN that often.
Right. And never feel weird about, bringing something to your doctor's attention, because it could be, and always get a second opinion if you just have a sense that something's wrong. I think your body.
Agreed.
Well, awesome. Go make your pap smear appointment if you haven't. And we'll see you next time. Thanks, Jenna.
See you soon.
Thanks for tuning in to From First Period to Last Period. If you enjoyed today's episode, be sure to hit subscribe so you don't miss any of our future conversations.
And don't forget to share this with your friends, because when it comes to women's health, we all deserve to be informed, empowered, and supported.
Still have questions? Email community@rescripted.com for a chance to have yours answered on a future episode. For more science-backed women's health content that meets you exactly where you are, head to rescripted.com or follow us on social @HelloRescripted.
We'll see you next time with more real stories and expert advice.